how our hospital group is leveraging IT within the organization. Though the topic says best practices and solutions, we presume it's the best practice and solution for us. And I'll be sharing some of our concerns and issues that come up while we're doing it. Just to give you a brief on our group of hospitals, this was the first corporate hospital started by a group of physicians, managed by physicians. Way back in '97, a group of cardiologists started a 50-bedded heart center. This group had to its credit performing the first balloon angioplasty in the country in '84. In '97, they left government service and started their own institution. And when we started this hospital in '97, everything was manual. Case records were manual, admission was manual, billing was manual. The only place where we used a computer was to generate our angiogram report. That was on top. We have come a long way since then. And most of the doctors in our place, including me, we belong to an older generation, though not prehistoric. We were never exposed to technology. The only technology we could see when we were medical students was an ECG monitor. We had a single channel monitor with heart rate. That's about it. So when somebody talked about hardware then, it was nails, nuts, bolts, and paint making. Software was something unmentioned. In '80, we saw people bringing in computers into use, equipment using electronics, and late '80s, early '90s, we had people who always took on to the latest in technology. And I had something which I would always send them. I somehow found this, which I preserved, because everything in those days was blamed on computers. You generated results, you generated bills, something wrong with it, everybody would forget they put in garbage, they're out of garbage. They would say, computer ka fault hai sab. Everything was that. So I used to send this to all my friends who were computer savvy, irreverent view of the computer, and you have the interface, you have the input, output, because basically when people used to put in garbage, get garbage out, I would say this is the computer that you have. So coming back to the topic, when we wanted to automate all our records and at least our business processes, this is way back in '99 that we first started it. We got on up to a partner. Karishma was mentioned there. And they were the people who first did the HRS for us. It was a basic system where patient interactions of registration and billing was all done by the system. Then in 2002-03, we had a relook at our system, 3.4 in fact. We didn't demolish and build a new one. We renovated and expanded what we had. We built on the platform that we already had, added new features. But though billing and everything was done through the HRS and the HR, everything was done. For accounting, our accountants still preferred to use Tally. So we were two systems, different systems working, and we managed with that till now. One of the issues that we always faced was the MIS reports here did not tally with the Tally, what Tally was showing you. So there always would be some discrepancy, and you would wonder where did this money come from or where did it go. So with a long-term perspective in view, the last couple of months we've been looking at a different arrangement now. And like I put it here, that the growing pressure in healthcare industries, not only to monitor the care that is being rendered, but to demonstrate the data, the patient safety, quality of patient care, cost effectiveness of the care, and also analyze all this and react upon this. Then the need for integrating technology through the processes to maximize technology's impact, sharing information, clinical process improvement and standardization across health system, practicing evidence-based medicine, and having a sustained organizational and cultural change, of course, transfer of knowledge and effective communication. With this in view, we are now going in for a platform where we continue to be wedded to Karishma. We are building a totally new system. And for the ERP, we are going in for Oracle Financials. And I'll share the concerns we have about this and how we are going about with this issue, as well as the Somebody asked about telemedicine and the Pan-African network. We are a part of the Pan-African network. Our hub is located at our hospital. And telemedicine also, we've started doing extensively with 2002, the government hospital. Basically consultation, and we were using one of the first to use packs way back in 2000, developed in-house, and we give opinion on the images that we get from a government hospital, which is located on a highway, Hyderabad-Bangalore highway. So that a lot of people who are taken to that hospital get the opinion of our doctors here, and a lot of trips to Hyderabad are saved and patients are taken care of there, and those who need care in Hyderabad can be moved to Hyderabad. Now we have gone into rural health care. We are working in Yavatmal area of Maharashtra, and I'll just share some technology innovation that we are using there for that area. Now, one of the first things that we had to look at when we were going in for our system is we had to answer all these questions. Will it reduce my work burden, the various stakeholders, the doctors, the patients, the hospital workers, and how much training is required for them? Would it help them plan their day's work? Would it increase the quality of output? And most important, would all of them get the information they need, when they need it, where they need it, and in the form they need it? And would their communication improve, cutting down costs at the same time? And would it make the patient happy? Okay, technology is something companies say, we have got the best technology, or we got a good HI system. But is it going to help the patient in the long run? Is he going to benefit out of what we are investing? Because ultimately, whatever investment goes in, there's somebody who pays for it. The patient pays for it. So, and for the manager, would they be able to delegate? And most important, would everybody say, can I become dispensable? Because once we automate, people become redundant, it's more on automation. Now, one of the most important issues we had to ensure for digital healthcare was involving the clinicians. Because they play the central role. Whatever you have, so far, whatever we had, like we mentioned, all the requisitions, be it lab, be it pharmacy, everything is entered by nurses. Whatever the doctor, physician enters is probably the case sheet, or even there the junior physician, junior doctor, resident enters in the consultant that signs it off. Getting doctors involved in data entry and using the power of IT is something that is very important. And we have gone through a couple of workshops, a couple of interaction sessions with the doctors. Though all of them do carry laptops probably to browse and use it for emails, but there are some who have started using it in the, we have got our own in-house OP module which we have developed. Some doctors are using it to keep a record of their OP patients. Then, because this ultimately would change their work too. And they have to realize that there's benefit when we have automation and standardization. And I'll come to that later on the standardization. And also, we have created a forum for suggestion, advice from the clinicians. But it's not that we say the management wants to do this and the clinician has to follow. We take their inputs also, trying to see what is more convenient for them, what is it that they would like to use. Now, you all understand this is the healthcare community with whole lot of things happening in the electronics. You've got telemedicine, security access control. Then on one side, you've got the supply chain management. You've got the electronic patient records, the medical systems, and the clinical and the administrative systems. All these have to be integrated, and each one has to talk to the other. And like I mentioned, we've got Oracle, which is doing our ERP, and HIS from Karishma. And it's lucky for us that we have got the same HIS provider, and between the two implementers, they'll be working out on how the two systems will talk. And also having the same vendor, our issue of legacy records and all is taken care of, because they know it's their baby. They are the housekeeper for our records, so they better find a way to putting it together. Now, in our hospital, in the health, you have to use health information technology. The scenario is so big. We've got research management, teaching and research, bioinformatics, surveillance, ancillary clinical process, telemedicine, infrastructure, process management, eHealth, device integration, digital imaging, point of care technology, primary health care, and physician documentation. All these are the various aspects that have to be taken care of in the health information technology, and these are all the issues that we are addressing in the present platform that we are going into. technology is compliant with all global standards, HL7, ICD-10, and ICD-10 PCS, DICOM, DRG. Well, mention it, everything is there. And also integrating primary care, home care, mobile care, secondary and tertiary. Now, the EHR that we are having is a multi-layered approach we are having for this. We have the raw clinical data sitting at the bottom. We have the patient demographic, the clinical disease, assessment details, medication, lab results, scores. On top of this, we have the comprehensive clinical records that are sitting on this. The cardiology, cardiothoracic, orthopedic, various other imaging and divisions. On top of this is the knowledge layer. This is where all the help that the clinicians need, the doctors need, that's going to say, the clinical guidelines, the treatment options, the decision support, the knowledge-based protocols, and healthcare standards. And on top of this, we have the business layer, because after all, it's a for-profit organization, so we have our business rules to take care of the businesses. And ultimately, the access layer, and which is both for all the providers and the other stakeholders, mobile phone, PDAs, laptop, desktop, and everything encompassed in the technology framework. Now, that was within the hospital. We'll be going live towards the start of the next financial. Right now, it's under the implementation process. So we are going through the pains of, gestation. We've not yet come to the delivery stage phase. I would like to share something about what we are doing in the rural area. A quote from Muhammad Yunus says, "An individual poor person is an isolated island by himself and herself. IT can end that isolation overnight." We started working in rural areas around Hyderabad, and then we went into the Yavatmal area of Maharashtra because we have a hospital at Nagpur. Because now, starting in Hyderabad, a 50-bed hospital, we are now, care group is located in 5 states. We've got 13 hospitals in these 5 states. And there we shared a platform with the ITC eChopper. On their platform, we were initially running our covering where they had their chopper and their centers, village centers, we were running on them. Now we are moving away from that and having our own setup, and which is again connected to our Nagpur, and we have got a central center at Yavatmal. Now the issues anyway, everybody knows about it. For the provider, healthcare providers, availability, there's no availability of doctors, accessibility to healthcare, and there's no accountability. Quality of healthcare not standardized and compromised at times. We've got quacks, we've got everybody practicing all over the place. Then also for the users in the remote areas, remote villages, people are not aware of simple principles of health and hygiene. People are not aware of their rights, facilities, services offered by the government. This is most of a lot of government services are there, which unfortunately a lot of people don't reach out to because they're not aware of it. Then the question of affordability. More than 60% of healthcare needs are met by private sector, by out-of-pocket payment. But a lot of people in the poor, in the rural areas can't afford this. Then poor health is one of the major determinants of poverty, and vice versa. Healthcare expenses push a large percentage of people to below the poverty line. This is a thing quoted by all economists and everybody in the country. So this is what is happening. So we had to address these 3 A's of awareness, accessibility, and affordability. The problems of poor health awareness, difficulty of transportation, and unwillingness of doctors to travel, inefficient public sector, and expensive private sector. The implication of this was the unhealthy practices being the accepted norm, higher morbidity and mortality, and illness-driven poverty. The innovation that we thought of was satellite links, solar power internet cures, monitored VHCs, and accessibility to telemedicine, drug and sample transport comprehensive network, affordability, cost control, partnerships, and microinsurance. The solution is also using the innovation, preventive education, competent advice, service at the price consumer can afford. So, considering all this, we have a group of health champions in the village. There's somebody who's just worked up to 6th standard, more than enough, mostly ladies who can spare time. And they have been provided this handheld device. Now this has got a biometric system for identifying a patient, because asking them their name, age, address, one time and again, people might not be giving you the correct details. And also for us to identify the individual once we have the insurance, micro-insurance in place. So this would carry, this is a handheld device which can communicate with through a cell phone with our central hub, with the hospital that we have where a doctor will be there. And through a stylus, the health champion can enter the patient's complaints. There's also a basic algorithm for symptom-based treatment for OTC drugs, which she will be carrying and she can give. Anything beyond that, the information from this is transmitted to the doctor. And this also, it's a little huge, not the ordinary PDA, because we've also incorporated a printer in this for the doctor's prescription to come through. So that from the remote end, the doctor gives his prescription for ailments which are not, which the health champion is not capable of treating, or the algorithms that she has cannot help her out. Then the doctor has to send in non-OTC drugs on a prescription. That comes out here on a prescription. And the identifier of each patient's always, only the patient's registration data sits on this, the algorithms sit on this. The rest is all in the central server. The communication is through this. And it can be charged, it retains 6 hours of charge after each time it is charged. And we are trying to make it into something which pays the village worker, because the OTC drug that she gives is a sale that she makes, either through micro-insurance or direct. So it's a cheap, portable, versatile, easy to charge and easy to use, cardless user identification by biometrics, because even if it's thought of issuing cards, people might not carry their cards all the time. So their best is use their thumb, and that will identify the individual. Only the first time they are registered, we have to make the entries. Automated activity list, decision support system with the algorithms that are there. Printer for prescriptions and receipts, because when she collects money, she can generate receipts also. And point of care diagnostics. And since it has a USB port, we can plug in all the other equipment which are now available for remote diagnostics. Well, in conclusion, I wanted to keep myself short.
Thank you very much.
Open for questions. We believe in this. When technology touches the compelling need, mindset for support is natural and automatic, and this is what we are dependent on from our clinicians. Thank you.
Thank you very much.